So Judge Sloan, going to be somebody we meet in person, actually, just 6 months down the road. Had a little talk. We're giving 6 weeks in a row down the road in Atlanta. Where
that I will be giving because you're not going to be there. So yeah, he gets to be our moderator. We met him at our little moderator meet the people meeting. So we had to steal him.
Yeah, made him give a talk. All right, so a few announcements. We have a lot of echoes, really good ones coming up. So please feel free to kind of look through the list. Next week,
Why do we have 2 scheduled for next week?
Oh, I hope we don't have a problem there. But we'll check on that.
We will.
But I believe next week for sure, we're probably going to be doing the community and substance use disorders and the LGBTQ. That's hard to say.
LGBTQ plus community with Mika, who is one of our Augsburg PA students. So.
All right. So lots of good ones coming up.
So, of course, free CME, you're going to get the link at the end. In the chat, you'll find that. Otherwise, in your email. If y'all could turn your videos on, that would be fantastic. I'm not allowed to eat, but you all can. If there's more than one person in your room, please chat that in. If there's questions that come up throughout, feel free to chat them in. Otherwise, at the end of Judge Sloan's presentation, unmute and ask away. Otherwise, if you chat them in, we will keep track of them and help moderate that as we go through it.
Yeah. Remember, if you need any help with any patients, please give us a call. You can reach out to Aaron as well. All of our phone numbers are there. We get lots of fun calls. So feel free to reach out.
And the online sites, the resources are there, how to get on echoes. If you missed one and you want to watch an old one, you can go there as well.
And remember the Addiction Connection podcast. We just let loose one Tuesday, and it was on.
Was it rural things again?
I think it was on rural opioid use in the rural communities. It was based on one of the echoes we had, some of the information from there. So please feel free to check that out. This is actually from my previous one. So go through that.
We're going to just skip this. That. And then I'm just actually going to take them down. So we will introduce Judge Dwayne Sloan. So from the state of Tennessee, like we said, we met him virtually. He will be moderating our talk in Atlanta this year. So I'm going to let you introduce yourself even more because you can do that way better than I can, and share your slides whenever you are ready.
Well, it's an honor to be with everyone, and very much looking forward to Atlanta and getting to be with you in your session. It's going to be so powerful, and appreciate the work that you do. So let me go ahead as far as introducing myself. I'll go ahead and let's see if I can. It's been a minute since I've uploaded my slide, so let's try to do that now. So. All right. Again, apologies, guys, but let's get rolling. Okay. So, I'm Dwayne Sloan. I'm a circuit court judge in East Tennessee. I serve 4 counties that are. It's a mixture of rural, kind of suburban. It's Cott, Granger, Jefferson, and Sevier counties. It's kind of we border North Carolina, and we're 1 county short of going all the way to Kentucky, and so a lot of rural space. One of the counties that I serve in is Sevier County. That's the Great Smoky Mountains National Park. Maybe some of you have visited there. Gatlinburg, Pigeon Forge, action-packed Pigeon Forge, where Dollywood is, and Sevierville. But that's where I live. In the early 1990s, I was a drug trafficking prosecutor. You guys remember the crisis of the day was crack cocaine, right? So I was actually federally funded to do those cases. Really passionate about it, learned a lot. But one of the things that I learned, and anyone that does that kind of work learns early on, is that you can't win the war on drugs on the supply side. You have to win it on the demand side. And I was fortunate enough to be elected at a really young age, relatively young age, at 35. And so in 1998, I had a really strong desire to try to help people that had substance use disorders, mental health disorders, that were justice involved, and really didn't do a good job with that. And actually did a lot of harm, even though I was trying to help. But I heard about these really awesome things called drug recovery courts, and we got to start a drug recovery court actually in 2000. 2009, and you get a lot of really good education as a drug recovery court judge, or you should, and the whole team. And we were actually into our drug recovery court for a few years, and here I'm thinking I really now I understand substance use disorder. I understand what addiction looks like. I understand what recovery looks like, what to expect, not to expect. And then in 2011, my wife and I got a telephone call from a maternal from my grandmother, who already raising, common story, right? Two of her child's children, her grandchildren, because mom had opioid use disorder. Now polysubstance use, she used everything, but opioids were a choice. And back then it was, mainly prescription pills that were, and she was actually prescribed. And when she delivered their third grandchild with her, Joseph, and but the grandmother was asking if we would consider adopting Joseph, and he was born with neonatal absence syndrome. And so he came, we agreed to that. And but reading through he spent 52 days in the NICU, going through the withdrawal process, and before he was able to come home. But reading through his medical records and just the horrific suffering that he encountered in early on in his life, and just he couldn't even sit up. He's 6 months old when he came to us, and that I knew then and there that I really didn't know anything about addiction, particularly opioid use disorder, because I didn't understand what was so powerful that a mother with that most precious gift of life inside of her could continue to use throughout her pregnancy, knowing the harm it was doing to her child, herself. So it was then and there I committed myself to take a deep dive in to really understand opioid use disorder and do everything I could to address neonatal absence syndrome. And what that ultimately led to was what we're going to be talking about, or spend most of my time talking about, the Tennessee Recovery Oriented Compliance Strategy. But so as all of you know, though I'd gone through several sessions with some really good education, but I really didn't get the power of the cravings. And what I understand now that I didn't understand then was that, my child's birth mother, her cravings were so powerful that for her, continuing to use was a matter of survival. And but in any event, I started, took a real, and again, was a real driving force for me, and still so passionate about it. But to help with neonatal absence syndrome, you have to be able to help mom. And so very passionate about it. I'm glad we're not in person. You might throw rocks at me, but I will remind you that we're going back to 2011 and my educational process. But I had a real bias against the medications to treat opioid use disorder. And that's common. You might have experienced it in your communities with people that judges, prosecutors, law enforcement, and it's gotten a lot better. I'd assume there in Pennsylvania as it has everywhere. But, commonly the people that use methadone or buprenorphine, our experiences were not that great. I mean, it's the being diverted, they're justice involved, all the things that you normally associate with the stigma related to those medications. But I did, like I say, I committed myself to take a deep dive in. I did, and but I would look at studies though about the efficacy of the medications, and as it related to the children, not a lot was out there. There's a better study or two that's been published since, but but it suggested positive outcomes but only children up to about 3 years old. But so again, I'm trying to learn and keep an open mind, but I had a bias against it. So moms that they would test positive with, let's say, buprenorphine, and because they're justice involved, okay, felony court, criminal court, justice involved. I would ask that mom that she would come into court to talk about it. And so this is how this thing got started. Again, my bias against the medications, but I would ask, all right, so you're using Subutex, right? Yes. So you have an opioid use disorder. So you kind of look at me and go, huh? I say, you're addicted to pain pills, right? And yes, I am. I said, well, so what treatment are you getting other than the medication? And every time the response was the same. Well, Judge, I see my doctor once a month, and I take the medication like I'm supposed to. I said, well, what else though? I mean, are you doing anything to assist what mainly it caused you to start using to begin with? And the answer every time was no. There was nothing else, and it wasn't that the physicians didn't care, but they just weren't set up to be able to, I guess, refer to places where they could address what was driving the addiction to start with. And so we're fortunate enough, and I'll talk about it in a minute, set up to be able to help these moms to link them to the care that they needed to address the drivers of their addiction to begin with. So moving right along. So what's everyone here knows, I'm sure, who has the most successful long-term recovery rates in the nation, I guess, in the world, right? Physicians and airline pilots. And showing their studies showing that they have recovery rates of up to 90% if for their successful compliance with those programs. So so there are three essential components that make up these programs. And one is an accurate assessment and referral to the appropriate level of treatment for the appropriate amount of time. The second component is frequent accountability, and third is leverage. So if you're a physician or airline pilot, right? I mean, you have a good job. You have the ability to be able to receive the treatment that you need for the right amount of time. That's not an issue. We're not going to just throw you away. And you have frequent accountability. I know a good friend of mine, Dr. Stephen Lloyd, best addiction medicine specialist that I personally know so far, but he phenomenal guy, but became addicted himself using 100 Vicodin in a day. Actually, if any of you've seen Dope Sick, the Hulu series, the character Michael Keaton plays after starting to see episode 3 is based on Dr. Lloyd. But he's been in recovery for, I guess, over 18 years now. But when he sought treatment, I mean, not only did he get the care he needed, he had the accountability of the Tennessee Medical Association. And he had to screen. He was accountable to someone, another physician. And number 3, he had leverage, right? There was leverage. What was the leverage? His medical license. So those 3 components, in my view, is what helps drive the most successful recovery-oriented compliance strategies. And where else is that found? It's actually found in the world that I live in. And as far as the criminal court work that I do civil and criminal court. But drug courts, and I don't know how many of you are familiar with drug recovery courts, have been a part of them, but they're fantastic. Again, I do that, but they cannot serve everyone. And there's like 144,000 people in drug recovery courts nationwide, 2,000 in Tennessee, but we're probably all familiar with this, or maybe you're not, but approximately 60% of the people that have experienced incarceration could be diagnosed with a substance use disorder, 80% of those people with a co-occurring mental health disorder. Drug recovery courts cannot serve everybody. We're mostly equipped to serve high risk of recidivism, high behavioral health needs population. So we need all hands on deck to address our current situation. So the Tennessee Recovery Oriented Compliance Strategy, what we call 10 ROCS, serves this gap population. Kind of just real quickly, an example of, like in Tennessee, there's 78,000 people that are on supervised release, probation or parole. And so 46,800 of those people will have a substance use disorder. Only 2,000 people served by drug recovery court in Tennessee, and our average population per court in Tennessee is consistent with the national average. So we have an opportunity with approximately 45,000 other people. So the three essential requirements of 10 ROCS or a successful recovery-oriented compliance strategy are as follows: that we need a trusted person or organization to provide that accurate screening, assessments, and referral to the best available level of treatment. In Tennessee, we're still not a Medicaid expansion state. Things have gotten a lot better over the last several years as far as people being able to access treatment, but it's still a problem. So that's the reason I say best available level of treatment. Need a trusted person or organization to provide the appropriate level of supervision, and three, personal organization that has the sufficient leverage to keep the person engaged in the process of recovery. The way this works, going back to mom that would come into court, and I would have this conversation with her, I'd say, all right, this is Elizabeth Francis. She's our criminal justice liaison, and she's going to be able to she's going to do an assessment with regard to your substance use disorder, and if a mental health need is indicated, she's going to make sure to get an assessment done for that, and she's going to do all the work. She's going to do all the work for you to schedule the appointment. You just have to show up, or the appointments. You show up, you stay engaged. This is now a condition of your supervision. And but now most of the time, and the way this is now is not the people that are involved in 10 ROCS are not out. The criminal justice liaison actually encounters them while they're in jail before they're sentenced. And also next you're going to see your probation officer once a week to make sure you're showing up where you're supposed to show up, doing the things you're supposed to do, to be available to you, to help you with any needs that you have that she can help you with. And then you're going to see me once a month. So the criminal justice liaison meets the person in jail, and this now we've been doing this since 2013. We'll meet the person in jail, does the assessment, arranges for develops a treatment plan, and then that becomes a condition of their sentence. And the summary of the recommendations made by the liaison are distributed to the judge, the prosecutor, and the defense lawyer, usually the public defenders, between arraignment and next court date. So we're trying to get people that are going to be released, assessed, back out in the community as quickly as possible. Next, they see the probation officer when they start out through stabilization, typically 4 or 5 months. They're seeing the officer once a week to make sure that they're complying with the treatment plan and addressing any needs that they have. One of the things that makes 10 ROCS work is if someone's running a wheel off, they have a high risk of overdose death, for example, and they're not showing up to the OTP or their clinic, then and they've been shooting 5 grams of heroin in their neck every day for several years, something's up, right? So the officer can contact me immediately, for example, and the lady did exactly that, 5 grams of heroin every day in her neck, doesn't show up to the clinic one day. The clinic calls the officer. The officer calls the liaison. They all try to get in touch with, let's say, Wendy, and within 5 more minutes, they've contacted me. Within 5 more minutes, I have a warrant signed electronically into the sheriff's hands to go arrest Wendy if we can find her, right, and did. But why did I do that? It was not to punish her, but to save her life, to get her back into custody so that we could then come up with a new plan. She's still alive today. That's 3 years ago, and she's thriving. Next, where can you apply leverage? You guys probably all know so many people that care about people that are adults that have a substance use disorder, and they wish they could make them show up for treatment. Well, as you may be aware that the studies have shown, whether you're basically forced into treatment or you do it voluntarily, statistically there's not any difference. The magic is to keep people engaged, right, for long enough to where that brain starts waking up and they develop a healthy network of people that they're associated with. They're connected back with their family, those things, and they're working, and they start enjoying life. And so that's a secret, to keep them stay engaged long enough for that to happen. But so I have what a lot of people would like to have, is the ability to basically, if you don't comply, okay, I can put you back in jail. Now, so the way this works, when they start out, about once a month, they'll come into court, and basically I'm just having a conversation with them, and it lasts about 3 minutes. Sometimes it can go longer, to just kind of review how they're doing. But and have a conversation with them. Now, most of the population that, and we have over 600 people in this, and 10 ROCs now in Jefferson, Granger County, where I do criminal court. That's a population, Jefferson County, 55,000, Granger County, 22,000. And that's about 50% of our felony supervised release population out of those two counties. That's a lot of people. So, but I have a 3 to 5 minute conversation with them. And it really is about just how are you doing? Asking the questions basically to find out how they're doing as far as, physically, mentally, are they engaged in their community, all those kinds of things. And, but most of the population have high adverse childhood experience scores, as you might imagine, right? They're not used to people in authority sitting up there and telling them that they're proud of them. But I guess it's best I can just do this. This next slide kind of demonstrates the point. This young lady here, if the arrow's clicking, I can't really see, is Mally Moore. The day that President Trump announced that the opioid crisis was a public health emergency, she was invited to be one of about 30 people to stand behind him. And Mally had, she was batting 1,000 with her adverse childhood experience scores. And, but, didn't even remember giving birth to her second child, and came into our program with her third child. And and now she's actually works with a very good clinic to help people in recovery. The guy here, and then, again, it took me 3 to 5 minutes, right, to have this conversation. That's basically my part. He's from Staten Island, New York, and I got to meet him actually at the White House a couple months after this. And all the cabinet was there. Anybody had anything to do with the opioid crisis, and President Trump comes in at kind of the end and starts engaging people in conversation. This guy stands up and he's kind of quivering, and he says, President Trump, appreciate everything the administration is doing to address the opioid crisis. And I can't imagine, can't believe I'm here in the White House, but he said, but it's just, I'm blown away. He starts like choking up, about to cry, and waves his hands around. He said, but I'd give all this for 5 more minutes with my son. Well, the son had died from an overdose, and he had an opioid use disorder. And, I think, about that, and the 3 to 5 minutes that I spend having a conversation. And, studies have shown that how important it is for a person that has a judge that is engaged with them and will spend that time with them. And I've spent 3 to 5 minutes. I'm thinking, I spend 5 minutes with somebody that maybe a dad that doesn't have to go through the horrible grief that this man went through to save their life. I can tell you the most powerful tool that I have in my belt is not putting the threat of putting somebody back into jail. The most powerful tool that I have is affirmation. I said there are 3 essential components of a successful recovery-oriented compliance strategy. Actually, the 4th is the secret sauce, and that's relationship. That's relationship that's built with that liaison. It's relationship built with the probation officer, and the trust and the affirmation they receive, they come to have and get from the court. So pass into 10 ROCs, our original sentence, and it's been an entire philosophical, cultural shift in our courts, but from anybody's going to be possibly be sentenced for a felony. The district attorney generals, the public defenders, basically a broad net looking at everybody that comes in to see if this is what was driving the crime to begin with, to make this treatment plan a part of the sentence. Violations of probation and even pretrial release. There's no eligibility restrictions like there are in drug recovery courts. If you're eligible for probation, you're going to go back out, then you're eligible for 10 ROCS. Scenarios really quickly. This in relation to the medication treated opioid use disorder, this lady here, she came to us the original treatment plan did not include a medication treated opioid use disorder. She went from jail to inpatient treatment, the classic detox. No medication was to help her except for the classic detox medication. And she was there at the treatment facility, inpatient treatment for, I think on her third day, she fled. Now, and this goes kind of way back, but after she was arrested, the criminal justice liaison got in touch with me and said, Judge, I think we need to try something different. And back then, I'm like, no, you know what? I'm going to keep her alive. I'm going to keep the baby alive, and I'm going to keep her alive at least till that baby's born. And I had trust in that the liaison, right? That she knew more maybe than I did, and that I needed to try something different. And so she got connected with an addiction medicine specialist, and then did not go back into inpatient, but began being treated with the medication. And she then gave birth to a healthy baby, maybe spent 6 days in withdrawals, good birth weight, and good outcome. She's doing very well today. And this, like I say, this has been many years ago, but in following the 10 ROCS. Now, we also have opportunity actually in civil court. And this guy here, we'll call him Sam, that he can, when a lot of times petitions will be filed for when a spouse or former spouse, father or mother has a substance use disorder, petitions filed, we want to change the parenting plan because of the substance use disorder. And classically across the country, that's just, all right, the parent's addiction, we're going to basically not let you see the child except for being supervised maybe. But we basically started applying the 10 ROCS strategy in our actually civil courts. And we have the same components. Now, the leverage is there is your desire to be to want to have time with your children, but instead of just automatically modifying the parenting plan and supervised visits, and now you come back to court several years later to get your stuff together and we'll do something different. Sam here had 50-50 parenting time, and he was with one of our trusted providers with the medication, and we kept rewarding him with more and more time. And after 2 years, he went back to 50-50 time with his children, and he works today for UPS and is doing very well. Yeah. So kind of play some of our success stories here. 10 ROCS again has been. We started it in 2013, and so in 2017 we were wanting to go to our then Governor Haslam to try to expand it in Tennessee again. But 34 of our first pregnancies were all born healthy. And this was, we've had many more since then. And 90% of those mothers, because we went upstream, engaged them into and got them connected to treatment early on. DCS, a lot, Department of Children's Services, a lot of times it's not even involved, but they continue to retain custody of those children. I can tell you now we have over 100 children that have been born that, and again, this is male and female populations now, 600 people, but we have over 100 healthy births. Still over 90% of those mothers are retaining custody of their children. Our more recent look back is crime was reduced over a 3-year period of time by 32%. We have our jail populations in Jefferson Granger County are running at about 60% of our capacity, and those jails 15 years ago are at or actually over capacity. We have a 50% reduction in overdose deaths, and a look back from 2013 to 17 in Granger County compared to the previous 5 years. One look back, 50% reduction in burglary rates there. But in scalability and implementation is much easier than your typical like drug recovery courts. It can be done anywhere, any court. It's very easy. Actually been published in the ONDCP Rural Community Action Guide as a strategy that could be implemented. Just real quickly, we got started a little bit late. We also have in Jefferson County, Tennessee, what we call an MOUD, Corrections Navigator Program. But everybody that comes into the jail has a brief screening to determine if they have an opioid use disorder, and we want to link them to a provider when they go back out. But we maintain people that already prescribed a medication to treat opioid use disorder. And we also do implementation. We've now had over 100 people in the program. We started a 1.5 years ago, and we only know of one person that's been charged with a new crime. We've had no overdose deaths since then with any of this population. I don't know if any of you have ever met Sam Quinones, but wrote Dreamland, but he gave us a visit there and with this lady's permission, but she got to meet him, told her story, and it was just incredible, but common about what she went through as a child. And Mr. Quinones, I mean, all I could do, and he's heard a lot of stories to keep from crying, hearing her story as she told it to him. But this is our Drug Recovery Court Christmas party. As I mentioned earlier, I mean, relationship is the secret sauce, and as you all know, the relationship, not recovery, is the opposite of addiction. And I'm going to believe that to successfully address our nation's situation with drugs in general, but particularly opioid use disorder, we got to go as far upstream as possible, meet people where they are, and provide them with hope and healing. So, all right, there we go.
Okay, yeah, we just really total not ask a question, but we got to meet Sam in October. We went down to Nashville and he did a presentation for us on the same echo. That was
good.
We got to have coffee with him, although he doesn't drink coffee. He just likes
Yeah, great. Good guy.
Okay, my first question is not really a question either, is how on earth did you do this in a Republican state? And we can't do this in Minnesota. It's beyond my comprehension. When you're talking, just because the thing you kind of ended with was the, your amazing data is, your crime, your numbers in jail and all of that. How about other child protection? Patients who, have been through the system and now are out or whatever. What have your other child protection numbers done? Have you looked at that?
Are you saying child protection?
Well, yeah, child protection, like out of home placements for other people who maybe aren't necessarily in the system or in your courts. Has there been anything noticeable with out of home placement and other children, just as an effect of what's happening within the courts?
So that's, one thing I don't do. So I'm not the judge that even would make the custody determination in these situations. It'd be another judge. Sure. Because that in Tennessee, it'd be a juvenile court judge. Okay. And so I don't do that unless it's appealed to me. So I really don't have numbers there. I can tell you that one of the things that we are doing in Tennessee are we call safe baby courts that have had a lot of successful outcomes. Can't give you the numbers, though I don't have them. And again, it's the idea of, and a lot of those are even trying to go upstream before they're actually their parent is charged with a dependent and neglect and come into the system. But yeah, I'm sorry, that's just outside of my.
I kind of figured that was a little bit not direct, but I have a whole soapbox I could get on child protection and ACE scores and all that, and I won't, but
yeah, good.
We are doing, there's a lot going on in Tennessee, thanks to my friend Amy Koslick, educating the frontline workers and higher level staff about substance use disorder, what to expect, what to not expect. We're doing a lot to try to educate the juvenile court judges and judges across the board about, again, substance use disorder, methods of treatment, what to expect, what not to expect, especially when it comes to like drug screening. That's it's one little thing, right? I mean, that gives us some information about what's going on. Just because you're passing all your screens doesn't mean that you need to get the child back. Just because you test positive doesn't mean you need to not have your child, right? It's what's going on in your life. And so those are things we're trying to teach. And it's moving. It's moving. And we did an echo series actually around that with the juvenile court judges.
We've done a lot of different programs over the years, and there's times where, we come across something that we're doing that clearly doesn't work and we have to pivot. Are there any big things that you did during your program that you went, okay, this doesn't work, we've got to pivot? Maybe not.
No, no, it's, I mean, when you say pivot, I mean, one of the things, I guess the big thing is kind of what started it. It was my bias against the medications. It was shared by probation, shared by the DA, shared by law enforcement. I mean, so I guess that's the big pivot. And the 600 people that are in 10 ROCS, I tell you, the people that don't come back, or less likely, I should say, to come back into jail, are the people that are receiving the medication to treat their opioid use disorder. I wish we had a medication, right, to give us that leg up with methamphetamine and everything else, but yeah, that's the big pivot.
So there's a question. Do you have, and I don't know if you're aware of this, but mandated reporting for like pregnant women with positive or abnormal urine drug screens? Minnesota, we just kind of did away with mandated reporting. It's still recommended as like a person who's doing obstetrical care if they have an abnormal urine. Do you have that in your state? And that might not be something you're aware of in your.
Yeah, no, I can answer that. I think your question would be if they test positive with a probation officer, or the probation officer has records from, example, a clinic, and it's a positive, are they mandated to report it? The short answer is no. However, what the mandate is if you school systems, probation, anyone would have a mandate to report if they thought that the child was subject to harm or abuse, I guess would be the right word. And so that's a matter of discretion, really.
Right. So with these assessments, so this is obviously happening, post booking. How fast does that person come in and do that assessment? Is it right away, like right after they get booked? Is it after court the first time? Kind of just the timeline of that.
Yeah. So if we're talking about people who are going to come out in 10 ROCS, the criminal justice liaison will meet them sometime between their initial arrest and or arraignment, and then their next court date. And we try to make sure that happens no longer than 1 month. Now they're there anyway. Now some people will come in, and so the public defender represents most people, will say, this person needs an assessment right away, and ask the liaison to kind of move them up on our list, and they'll do an assessment, and we'll make that treatment plan a condition of their bail, right? So they're able to be released earlier. But the DA gets some say in that. I'll make the final decision on that. But to answer the question that now, again, everyone with the MOUD corrections program, they're screened right away, and then the assessment is done within no longer than a week, but usually within a few days, to determine what their needs are to get them linked with treatment going out. And and if once they're sentenced, then and they say we've had them inducted in jail, then they come out, they're going to be in 10 ROCS if it's a felony, but they're misdemeanors and felonies with the corrections program.
Sure. So they can get inducted even prior to having this evaluation.
No, they'll have, it's actually a separate, a different person that does the 10 ROCS navigator. I mean, not 10 ROCS navigator, corrections navigator. Yeah, they can get inducted, and we want them to get inducted as quickly as possible. But they got to meet, if they're going to be inducted, they got to meet some other criteria, like is there a hold in another county? Some of these kinds of things that you don't want to get it started, then they stop. Because there's a hold when we dispose of the case.
One of the things that we've really struggled with in Minnesota is really, in the county jails, getting county jails to understand how important it is to put buprenorphine in the jails. And, there's this whole concern about diversion and other issues.
Sure.
How do you look at that whole subject? Because we have some jails that are very positive and clearly have had great outcomes. What's your thought on that whole process?
Well, it's there. I mean, we face that, right? I mean, even though I had a sheriff on board, still just the process. I mean, you have the corrections officers saying, we've been trying to keep this stuff out of here for years. And now you want us to bring it in. And so it's a matter of, educating them and then just that willingness, local willingness to try. I mean, I always suggest to start small, like everything else. And for the corrections officers, then once they've gone through some training, some education about the medication, about the outcomes that are successful outcomes from other places, about how violent crime inside of the jail goes down, introduction of contraband goes down. You make those points. You talk about the medication, how we're going to do this, how we're going to be able to administer it. And there's always going to be diversion, but what you do about it, but how you can minimize it. But then they start seeing that people aren't coming in throwing up everywhere, and they start experiencing themselves. But it takes a minute. But I just think having stories from people that they're out there, right? That they were the corrections officer, they were the sheriff. It was the sheriff. The people that had that mindset that they were totally against it, to be able to speak to their peer. I can talk to other judges with a lot of credibility. I'm a former prosecutor. I can talk to those people. I can generally talk to law enforcement, but direct peer-to-peer is, I think, always the best route to take.
So with that, I just have to, on this call currently, there's at least four or five either current or past correctional nurses. One of the nurses on here was actually our first jail in Minnesota that Kurt and I were able to convince to do MAT in our jail in 2017. It's no longer happening because of exactly what you just said. And getting all of these people on board, which is very challenging. Thus our talk that we're doing in Atlanta. What is your healthcare system in your jails like? Is it, so in Minnesota, the health care provider is all contracted with the county, it's not typically, public health. It's not usually part of the same thing. It's a contracted in healthcare provider. How is it in Tennessee?
So it's going to vary. The metro areas may have their own, basically their own system, and they're not contracting out system of care inside the facility. But the rural counties they all contract with a provider, and it's usually a network. Southern Health Partners has the contract in Jefferson and Granger County, where I preside over criminal court. And interestingly enough, and now I've called them out by name, but interestingly enough, our biggest battle was with them. They're biased against the medication.
Wow.
And just kept throwing up roadblocks. But we got past it.
Well, I would
but
love
yeah, it's generally contracted.
That was one of our biggest battles. It still is. Yeah, that's interesting.
Yeah.
Another thing that in Minnesota, we have a lot of harm reduction committees and all of these things that, any decriminalization discussions there in Minnesota, that's kind of one of our things that we're going through right now is how do we decriminalize, some of these lower level drug charges or offenses. So this kind of process or assessment can happen even pre-booking, so pre-charges. Has that been discussed and thoughts on that?
Yeah, I mean, somebody's got to drive all this, it's not happening here. It's as we continue to move forward, obviously that's something that needs to happen, but I'm kind of tapped out with a lot of things that I do.
Yeah,
All
I
right,
hear you there.
Dave, back to Dave.
Can you hear me now?
Yep.
Okay, sorry. So I've had a couple people referred from the justice system when they were getting out who were on MAT, asking if I would see them, and I said yes, of course. And they stick around for a little bit, but it hasn't gone great. And I guess my question is, how can I improve the communication between myself and like their PO and their other support systems? And one question is, legally, can I do it? Can they talk to me?
Great question, Dave. Dave, what do you do?
I'm a family doc.
Okay, yeah. So I'm so glad you asked that. Because it would be so great for someone, a family doc, to be willing to take the time to do that, to develop that relationship with the probation officer or the court. But absolutely, they can talk to you. I mean, of course, you need your patient to give that consent, but absolutely try to build that relationship with the probation officers. Give them an opportunity to understand what you do, and because it's developing that trust with you, will go such a long way with helping your patient and the person they supervise, and will help that probation officer not only with your patient, right, but to better understand how to help the other people that they supervise.
Dave,
Absolutely. There's nothing, not to my knowledge, not anywhere, and I do a lot around the country, that would prevent the probation officer, unless it's just some state policy or local policy, to prevent them from talking to you. They should be talking to you. They should want to talk to you.
Right. Dave, the hardest thing we've found is the patient wanting you to be able to communicate with the probation officer. So typically I will bring that up right away. Like not right away, it depends on the patient, but I ask right away, do you have a probation officer? Do you have a case manager? And explain to the patient, my job is never to throw them under the bus with their PO or whatever. My job of anything, I can help advocate for them to that probation officer. So try to convince the patient that it is in their best interest for me to be able to communicate with their PO as their advocate. So sometimes that takes a little bit. The other thing it can sometimes help is the patient's cost on their urine drug screens. We've built relationships that, like the ones we're doing in clinic, automatically can get sent to their probation officer. So then they don't have that out-of-pocket cost when, the PO shows up for a random.
Yeah, or vice versa.
Right.
If I get the one from the justice system, I don't have to do one then.
Right.
Yeah, what I found is, like, they want to stay on the medicine. They just have so many other challenges, like transportation and all those kinds of things, that I would love to be able to talk with the PO and be like, hey, what can we do about this? So, and I'm not a lawyer.
Well, I applaud you for wanting to do that, and I would encourage you to engage your probation officer if your patient gives you that permission.
Okay, thanks.
All right, thanks, Dave. Other questions anyone has before Heather asks another one?
Sorry, this is like my topic.
Anybody else? All right, go ahead then, Heather.
Now, you mentioned felonies, you mentioned different misdemeanors and all of that. Is there a difference in timing on when they can get out and do the supervised release, or how does the supervision change depending on the actual charge? Is there a difference? how is that looked at?
All right, so if they're participating in 10, we actually have 10 ROCs in 11 jurisdictions in Tennessee now. So it's going to be, the idea here is it can be flexible and how you operate this. But of course, your question is to me and locally. So there, it's just we don't do misdemeanors very rarely unless they have a felony counterpart in my criminal court. So I'm really, I just don't do anything with misdemeanors. So I'm only dealing really with felonies. But I think really what your question is getting at is there a difference in when they're going to be released in the community? Maybe I'm missing that, but yeah, it depends. I mean, it's, one way to look at 10 ROCs is it's in large part a reentry program. So a lot of people they're not in jail because they tested positive for a screen. They're typically in jail because they've committed a crime, and recognizing that is important. It's important for like the local law enforcement to prosecutors to be able to, when they're communicating with a victim of a crime, to be able to, and it's true. I mean, there is a component if you're stealing, if you're burglarizing, if you're doing even more egregious criminal behavior, that there be a component that you actually have to serve some time. Now we do a lot of mostly what's called split confinement, but where they're in jail maybe 60 days, maybe 90 days, maybe 6 months, some people even a year before they're released. But if you're in jail on say a violation of probation, and sometimes this will happen because not only it tests them positive, but there are other indications, like the example I gave you earlier with Wendy. She's early on, she's been shooting heroin in her neck every day for 3 years, and she doesn't show up. And so she's arrested because she doesn't show up to the clinic one day. Now, most people go, my God, why would you do that? It's because we know what's going on in Wendy's life. We know, her history, and we're trying to save her. So Wendy, we're getting the assessment done, trying to get her back out into the right level of treatment as fast as possible. So that can be a matter of days.
Sure.
All right.